QI project using VQI data and DMAIC and Six Sigma quality principles. I'm Nadine Caputo, Quality Director for the SVS PSO, and I'm excited that we have two outstanding presentations. Our first presentation is a limb salvage pilot project that's being implemented at Roper Hospital in Charleston, South Carolina. The presenter and project director is Lori Bennett, Outcomes Manager and Lead Data Manager for the Carolinas Vascular Study Group. Lori has an MS in nursing with over 25 years experience in quality and outcomes management. Our second presentation is a QI project is being led by Dr. Catherine Heckman on reducing vascular groin surgical site infections for LEB patients. Dr. Heckman has completed the pilot phase of this project, and she is going to present her initial findings and QI perspectives. Dr. Heckman is a resident physician in vascular surgery at Northwestern Medical Center in Chicago, and she has a PhD and an MD from the University of Chicago. All of you have been placed into listen-only mode. Please type your questions in the chat box that's located in the lower right-hand portion of the screen at any time. We welcome your comments and questions, and we have allocated time at the end for Q&A. And all of the questions, responses, and presentations are going to be posted within a week of the webinar. And now I will turn it over to Lori Bennett to start us off. Lori?
Thank you, Nadine. Good afternoon, everyone. When Nadine asked me to speak with you today, I was delighted to have the opportunity to share with you how we initiated our limb salvage program project and created our quality project charter. First, to tell you a little bit about ourselves, Roper St. Francis System is comprised of 3 hospitals in the Charleston area: Roper, St. Francis Hospital, and Mount Pleasant. And we're a private hospital system that serves our Tri-County area. Today, I've been asked to walk you through the QI process and how to develop a project charter. If I can get it to go. Nadine, I am trying to,
there we go.
Okay, there we go, thank you. So this is the outline of what we're going to be discussing today. The first thing you're going to do is define, you're going to pick a project to improve. If you have an idea, this is going to get to your project, your opportunity, your goals. This is also when the creation of the project charter begins. The second step is measure, and it answers more or less why this, and it's data, data, data. It's baseline data and tools that are going to be used to collect your data, and this also includes the literature review. The third is analysis, and that's more or less the current state of affairs. This is going to be using your baseline data, your root cause analysis and trends. You're going to be identifying key players, constraints, and you're going to be doing a needs assessment. And it's also the creation of a new process to test, and that's called a pilot project. This is going to be following the Lean Six Sigma process and also the QI process that VQI has given us. Okay, now in business, committee membership. Our committee is made of stakeholders who are involved in the process on a day-to-day basis, and these people can significantly impact the implementation of your new process. The first meeting you're going to see has asterisks next to some people, and those who are our core members. And the core members are really going to be the ones who are going to give you direction as to the purpose, the goals, and the objectives of your project. The purpose of the limb salvage project. The first thing is the definition of limb salvage we use is an attempt to save lower extremity limbs from amputation due to peripheral arterial disease and also critical limb ischemia. The purpose of our project was to create a limb salvage program within the Roper St. Francis system to facilitate a formal process of patient referral within our Roper St. Francis departments and outside. The reason and baseline data, this is important. This is what your project is going to be building its foundation on. This is your amputation data. For us, we use the VQI registry for lower extremity bypass. We also have a scorecard of which we use the analytics engine. This is created quarterly, and the analytics engine is an awesome tool to use. We used amputation rate, patient volumes for type of admission, your length of stay, your financial mortality, some diagnosis and procedure data. The second thing was the lower extremity bypass, and this was your readmission, your diabetes management. How about the use of the hyperbaric oxygen therapy, utilization of your podiatrist and patient referral sources? I want you to note that the data is measurable and it's also countable, and this is going to support your statistical analysis when you get to that point. Measurable data is your amputation rates, your volumes, your length of stay, your financial, your readmission rates, and countable data would be such as your age, gender, zip codes, discharge, dispositions, mortality, because that's a yes or no, and diagnosis and procedure data. The next is your readmission. We also use that from our system, and that's TrendStar. And then your literature review with a focus on development of the hospital-based limb salvage programs. So what were the best practices? We also established the need for the VQI amputation module that we were going to be needing. Your literature review is going to be built, and it's going to be just your foundation, and it's going to give you your backbone for your project. The source of truth. This is our quality improvement process. When you're writing your project charter, if you know where your data is coming from, state it. Be very precise. You want to give data definitions so that everyone is on the same page regarding what the data does represent and also what it doesn't represent. For an example, what is a readmission? For us, it was equal to less than or equal to 30 days after hospital discharge. So if the patient was discharged at day 34, they were not counted as a readmission. You want to use national benchmarks and regional benchmarks. And this is your VQI data. It's going to be just an absolute source that you're going to have. We used our scorecard. We also took our data from the VQI registry and we dumped it into Excel, and we also created some specific reports. I've given you an example here on the screen. This is not real data, but I wanted to give you an example so you could see kind of what it looked like. Objectives. First thing is to standardize your screening, your diagnosis and treatment criteria. And this was utilized in the literature review. This is your theoretical foundation for the project. Examples are going to be your standards of care, templates, any benchmarks. These are your PI measures, your cost data. We also looked at other programs for limb salvage as to how they were created and what their outcomes were and what the outcomes so far have been. The lit review is going to help narrow your scope of your project, so you're not looking to save the world, but you are looking for something that you can change, and you want to start off small. For our first QI project we did on carotid enterectomy, and we looked at our length of stay, and we found out from our VQI data that if we didn't put a patient in an ICU and we had them urinate prior to going to OR and not use a Foley cath, that helped to go down on our length of stay. I want you to note that we've got some SVS and some QI-based journal articles. If you've never done a lit review, contact your hospital librarian. They're really huge help. Objectives continued as once the lit review was completed, we were able to state what we wanted to do. And we wanted to create a limb salvage program which facilitate a formal process of patient referral and collaboration. Third thing we wanted to do is increase the efficiency of the referral. And the fourth thing, we needed to meet with vascular surgery, the HBO, the local podiatrist, to create interest and secure buy-in. This was our core team. Remember on the very first slide when I showed you the membership? You want to be able to hear what your main players' interests are. This is going to help narrow your scope. It's also going to help keep you on track so that everyone agrees on the purpose of your project. What we heard was number 5 and 6. We needed to improve inpatient coordination of care through the pre-op assessment, coordination of patient care, utilization and discharge. But mainly, we needed to improve our outpatient coordination of care. And that was with using the utilization of our wound care clinic, the DTC and HBO units. An example of this was, who do you call a patient referral to? Here's the phone number, and here's exactly your contact person. After all was said and done, we ended up with our opportunity statement. It was the creation of a limb salvage program within the St. Francis Hospital network, which would facilitate a formal process of patient referral and collaboration between the Division of Vascular Services and primary care physicians, endocrinologists, podiatry, and family practice. Our goal, it was pretty much the same as our purpose. It was to increase the use of resources and consults by 20% CY18, which is calendar year 18. Notice it at the very end too, where we said in other primary care providers of physicians, we didn't say providers, we were very specific. We wanted primary care, endocrinologists, podiatrists, and family practice. Otherwise, you're going to have too much that you're going to have to put into. So you want to actually narrow your focus on this. The success of our project goal was demonstrated and validated by an increase of volume to our consults, and also a decrease of the amputation rate by 20%, decrease of readmission, and decrease of length of stay. You want to keep on track. You want to focus your project so that everyone on the team is going to naturally have some things that they're interested in. But what you want to do is just to get a focus there so that you don't drift off center. When you're defining your goals, you see that numbers 3 and 4 with the asterisk, those defining are still in progress. So you want to remember that targets may change as you develop your project charter and also before you implement your change. Remember your college research course? Clemson Tiger Pod, go Tigers. Okay, a goal has 3 parts. What are you targeting? How much? And this is a number, it can be a percent. This has to be a metric and it has to be measurable. And also the when, which is the due by date. For us, this meant looking at some of our stakeholders. Who are the people? What is the quality impact? What is the financial impact? And for services, what services would be impacted by our project? Remember, narrowing your project so that it's something manageable. This is called your project's scope. Right here, you're going to see who's included, all adult patients. And if you look down, you're going to see also who is excluded. Tools and measurements. This is going to help you find what software is, what your software is, your questionnaires, your EMRs. These are all called tools. Your measurements going to be your raw data. Those are going to be Excel data. That's going to be your VQR reports. You can use pivot tables. It's things that have to be measured, and it's at your actual baseline. Data sources were the VQI data query and analytics engine tool right there. You need a baseline source. Your future data is going to be compared to something, and that has to be your baseline. That's how you're going to know whether or not you've made any progress on your project. The analytics engine is awesome for this. Also, you're going to look at some of your financial data and make sure that the project makes sense to your wallet. You want to get the maximum bang for your buck. So it has to be worth the time and the effort of the group to actually do this project. If you're looking at financial outcomes, you want to go to your financial hospital system. For us, that was TrendStar. You're looking at final billing codes. These are the codes that go to CMS and also to your commercial payers. So you're going to want to look at your financial data. Your PI processes, you're going to need to name who those are. For us, it's Six Sigma. And we also use the VQI project guide, which is very helpful and will also give you a template for your project charter. You want to be aware of the bears. This is your Educationist staff, which is your staff availability and your schedules. Your members of your committee, getting times for everyone to join can be a problem. The purpose of the amputation module is something we need to do, and that has been done, and we're starting to use it. The communication with staff, and also education and communication with your community physicians once that your pilot project is done. This is DIMAP. This is your Lean Six Sigma. We've already talked about define what your problem is. You want to measure your key aspects. Analysis is you have, with your baseline data, you want to analyze it to investigate your cause and your effect relationships. And you want to look for trends. Your improvement is when you're going to be looking at your pilot projects, you need to test what you're doing with a small amount just to make sure that it's going to work. So you can implement it if you're doing a hospital project, implement it on one floor. Or for us, we were implementing it in our wound care center. You're going to want to implement it at something that's manageable. Control, this is to ensure your mechanisms are in place to sustain the improvements that you've made. The VQI data is going to be extremely helpful on this. This was for us is going to be reflected in our scorecard, and we look at our scorecard quarterly. And during the pilot, and even after for about a year, we'll probably be looking at that monthly. Maintenance is the key. It's kind of like having to maintain the 10 pounds that you lost last week and the last year, and you keep seeing it go up. Walking the Gemba. First, you have to know what your current process is. So you want to gather as much information about the current process as you can, and then you want to go straight to the source to make sure that this is actually what's being done. And you walk the Gemba with people who are actually walking this on a day-to-day basis. I walked the Gemba with our PA, Carol Britson, and also with my boss, who's Bob Hostler. And as you can see, the whole purpose for this is just, there's a whole lot of communication. I just wanted to show you what it looks like. For the analysis, the secret was all in knowing. Once we knew what the current process was, we needed to talk with the stakeholders to develop a process that would foster communication and collaboration between the various departments and the physicians to encourage and foster staff involvement. And ultimately, this is going to optimize our patient outcomes. Changes to the process, these are just a couple for us with this one. Mainstreaming the wound care consult, education, choosing the right test, and diabetes treatment center. How do we get a consult going to the CDE if it's an uncontrolled diabetic? This is the new process. This is the improvement part. It's off with the old, and we're going to start anew. There are 3 places where the consult begins now, and I've just put this up to give you an idea of what we're looking at. Complex patients means that we need to talk a lot among ourselves, but now there's a new flow, and a referral pattern has been created. And if you were to really look at this closely, you're going to see wound cares in blue, and then our surgical candidates are also in the peach color. And diabetes is going to go across the board to all of that, and we also have our HBO consults. The takeaway from this diagram is put it in writing. Make it as easy to understand as possible. Some projects can use a flow chart and some can use a protocol. Just make sure that your audience understands the process. This is where we are now. We're developing our pilot goals and our timelines with the committee. We're collaborating with our physician stakeholders as to looking as to who is eligible for hyperbaric oxygen therapy, how to contract the Diabetes Treatment Center consult. We're educating our stakeholders of the new process. And then once we have the process done and the pilot project has been completed, and we're now going to implement it across the system, we'll be working with marketing. I was asked to just give you an idea of what the project charter looks like when it's completed. And that is an idea, and that is what it looks like. These are my references, and I gave you my references also for the limb salvaging, for the pilot, in case you're interested in that. At the end of this journey, when it's all said and done, it's all about caring for our patients, and that's why we do what we do again and again. And so it begins another quality project. I want to thank you very much, and thank you for asking me to come and speak with you. I want to give my thanks to Dr. William Ashwander, Dr. Appleby, Dr. Blunt Ellison, Robert Hostler, and Carol Martin, and the Dean for helping me with the input into this project. We look forward to giving you an update as to where we stand once the pilot is over and once we have some data. So thank you.
Well, thank you, Lori. And now we're going to turn it over to our second speaker, Dr. Catherine Heckman. And we're just getting the slides set up, so bear with us for a moment.
All right. Well, as Nadine said, I'm Katie Heckman. I am a vascular surgery resident at Northwestern, and I am very excited to be here presenting the findings from our pilot quality improvement project on reducing groin surgical site infections for vascular patients. I worked with Dr. Andy Houle here at Northwestern on this project, so thanks for having me. So briefly, what I'm going to talk about is a little bit of background about what led to the project, going over the surgical site infection rates here at Northwestern, as well as in our regional group, as well as the national database from the VQI, and briefly go over some risk factors for surgical site infections in groin wounds from lower extremity bypasses. I'll talk about the development of our evidence-based bundled intervention and how we implemented it, as well as review our pilot study results and where we're going next. So surgical site infections are unfortunately not uncommon in lower extremity bypass surgeries. They are most common of the common vascular surgery procedures. Lower extremity bypasses have the highest rate of surgical site infections. Reported in the literature, about 8 to 10% of the time is how often they occur. We all know infections are bad things. They increase healthcare utilization, they require antibiotics, they prolong hospitalization, impair mobility, and they lead to an increased risk of graft failure that can result in loss of limb or even loss of life. So this project really all started back in 2015. We have twice monthly quality improvement meetings where we go over our morbidity and mortality cases within the Division of Vascular Surgery. And we sort of noticed a trend. We felt like, oh, we're discussing yet another wound infection, Maybe we should take a look at this. So we did. We utilized our NSQIP and our VQI data. When we took a look at our NSQIP data, this is our NSQIP sample data from 2015 for all vascular surgery procedures. And this is risk-adjusted data, as the NSQIP does. And it shows that we were doing pretty well compared to other sites in terms of our surgical site infection rates. However, when we reviewed our VQI data from 2015 specifically for lower extremity bypasses, again, this data is not risk-adjusted, but it showed that we had a higher rate of wound infections than other centers nationally. All the blue dots, every blue dot represents an individual center, and we are the red dot at a rate of 16.1% compared to the benchmark of 3.3%. So we decided that we should take a further look at this and figure out why this was happening. And I thank Lori for such a wonderful presentation about how to, the process of quality improvement and how to start a project. We also used the DMAIC method. I won't go into too much detail with that since she did such a wonderful job. Our goal was to better understand wound infections after lower extremity bypass. We suspected rather, that groin incisions were the source of the problem, given that the groin has a high bacterial load and is a difficult place to keep clean. So we focused on bypasses with groin incisions. We started by identifying modifiable risk factors from the literature and modifiable risk factors from our own data using the VQI database. Our goal was to track infection rates over time and implement a quality improvement initiative to reduce these infection rates. So when we took a look at the literature, there are a lot of papers that describe known risk factors for surgical site infections. Some of these include being patients that are MRSA carriers or that have active bacteremia at the time of surgery, patients that have risk factors for impaired wound healing, such as malnutrition, smoking, being a diabetic, taking steroids, or actively undergoing chemotherapy or having an active malignancy. Older age is also a known risk factor for wound infections, as is end-stage renal disease on dialysis, obesity, and actually having a prolonged preoperative length of stay. So after we pulled our data from the VQI and we submitted an IRB in order to get the identified data from the VQI so that we could supplement the VQI with chart review. And we took a look to see if any of these known risk factors varied significantly between our institution, the region, and the nation that could explain potentially why we were such a high outlier for lower extremity bypass wound infections. We found, however, that we had comparable rates for the median age, male gender, percentage of patients with diabetes, percentage of patients with end-stage renal disease on dialysis, obesity, and current smoking status. The one factor that emerged as somewhat different was the percentage of patients that were outside hospital transfers, which in the literature is often interpreted as a surrogate for complexity, possibly correlating with reoperative status or anatomic complexity, which both can lend themselves to increased risk of wound infections. You can see here we had, amongst our infrainguinal bypass patients, a 10% rate of outside hospital transfers compared to the regional rate of 4.8% and the national rate of 7.4%, so slightly higher. We also decided, so those factors did not seem to explain how our outlier status for wound infection. So we decided to look at our data for any modifiable risk factors. We chose not to focus on risk factors that were already routinely modified. Those are risk factors that are already addressed by the Surgical Care Improvement, or SCIP project. This includes timely administration of appropriate antibiotics for surgical prophylaxis and sterile prep. This also included things like intraoperative normothermia and perioperative euglycemia, which are known to affect wound infection rates. So as you can see, when we looked at our VQI data, we were doing a pretty good job compared to the region and the nation in terms of our antibiotic prophylaxis and our sterile prep So when we did take a look at our data to identify risk factors that correlated with wound infections, we looked at some of the common risk factors we talked about: male gender, hypertension, being a diabetic, the use of prosthetic, having a prior bypass or being a reoperative patient, the indication being any form of critical limb ischemia, having an infected wound preoperatively, the use of a drainage system postoperatively, such as a Jackson Pratt, and not having any shower postoperatively while in the hospital. The only factor that emerged as positively correlating with wound infections was being diabetic. Unfortunately, this is not a readily modifiable risk factor for most of our patients. So this did not lead us to specific interventions for our bundle. So we relied heavily on the literature to identify risk factors to intervene upon for our bundle. We also took a look at non-binary variables as well, and none of these emerged as salient factors responsible for our wound infections. So we took a look, like I said, at the literature to identify interventions that we could bundle to improve our wound infection rate. Bundled interventions have been successful in reducing surgical site infection in other surgical subspecialties such as gynecologic, orthopedic, and colorectal surgery. Specifically, bundles that are implemented across the various phases of care during the care of the surgical patient are effective and have high compliance. So we divided our phases of care into pre-operative, intraoperative, and post-operative phases. And from the literature, we selected our bundled intervention components. For our pre-operative phase, we as a group chose to focus on pre-admission showering with Hibiclens prior to surgery. This is based on a publication by Edmonds et al. In JAMA Surgery in 2015, where they evaluated the concentration of chlorhexidine on the skin in healthy volunteers after 2 or 3 showers. This was a surrogate for outcome for the antimicrobial effect, and they found that there was a significant increase in skin concentration with a pause after application of the soap before rinsing it. So we implemented this protocol. We provided our inpatients and our outpatients with the chlorhexidine. We instructed them to shower 1 time the night before surgery and once the morning of surgery with a 1-minute pause, letting the soap stay on their skin before rinsing. For our intraoperative phase, we focused on the type of groin incision based on a study by Swinton et al. From 2009, which demonstrated that when comparing vertical or transverse incisions for access to the femoral artery, they found that there were lower rates of wound complications, infections, and breakdown, as well as lymph leaks with transverse or oblique incisions as opposed to vertical incisions. As you can see from the images included in the paper, there is less tension on the incision with the oblique or transverse incision versus the vertical incision, both when the leg is extended and when the hip is flexed. For our post-operative intervention, this really wasn't, it was a little bit harder to find good literature suggesting post-operative components to intervene upon. So this really was based off of discussing amongst our care team, which included our attendings, our fellows and residents, and our in- and outpatient care nurse practitioners who participate in the care of our patients. And they really felt that our patients were struggling with motivation and the ability to really just have good hygiene after surgery, which contradicts the CDC's general guidelines for the prevention of surgical site infections to maintain a clean and healthy wound bed during healing. So our post-operative intervention was to include a chlorhexidine shower on the 2nd day after surgery. So this is our complete SSI reduction bundle. We did a preoperative showers, 1 the night before and 1 the morning of surgery. We recommended a transverse groin incision intraoperatively, and postoperatively we encouraged our patients to shower on day 2, which is typically the day that they would take the dressing down from the groin incision. So we implemented a single-arm prospective consecutive and rolling quality improvement initiative. Our inclusion criteria were patients who are undergoing or may undergo a vascular bypass for any indication and would have a groin incision as part of that procedure. Based on our wound infection rate of approximately 13%, in order to detect a modest reduction to 10%, our power sample size calculation was 410 patients. We initiated this bundled intervention on March 1st, 2016. This included training our vascular team and training our nursing staff taking care of our patients, both in the ICU, 12 West and 11 West, which are wards here in the hospital. We completed a rolling evaluation every 6 months to assess bundle compliance and our infection rates. And we had ongoing team training and feedback sessions in order to refine our protocol. So the logistics of carrying out the implementation of this, I think Lori did a nice job of highlighting how many different points of communication you really need to have in order to be successful in this. So we educated our care team by conducting individual meetings with the outpatient vascular team. One, first to inform them of what the problem was and what our plan was, and to solicit their feedback on how to make it better. They gave a lot of really useful feedback on the written materials that we would provide to the patients in the outpatient setting in order to make it clear how to conduct the showers. And I continued to meet with them as well to see how it was going and to assess if there were any barriers from their end. We used our bi-monthly QI meetings with the inpatient vascular team in order to educate them about the problem we had with wound infections and to solicit their input. And that's really where we got the idea for the post-operative shower, was from talking to our team members and their observations and in their daily routine of caring for our patients. In order to educate our nursing and technician staff, we attended morning huddles as well as nursing quality initiative meetings on the floor and had one-on-one meetings with nursing leadership in order to figure out the best way to implement the bundle and to assess compliance. In order to remove barriers to access, we ensured that chlorhexidine was stocked both on the floors and in the outpatient clinic. We submitted a ticket to our IT system in order to have the shower orders built into the order sets so that it would be a simple checkbox for our care providers in order to make that happen. And we provided patients with written materials, as I mentioned, in the outpatient setting, but also we had laminated placards that they could hang on the whiteboards in their rooms so they could check off when they completed their showers. Documentation was probably the toughest aspect to implement. We built in a checkbox for the preoperative shower into the note template for our preoperative H&P. Our type of groin incision was already routinely being documented in our operative notes, so that was already in place. And then assessing compliance with the post-operative shower was probably the trickiest part, as we had initially, there was a little bit of misunderstanding rather between the nursing leadership and the nurses who were actually performing the tasks of helping patients with their post-operative shower. We were led to believe that the documentation was occurring in one place, and we initially thought we had a very low compliance rate, and after talking with people and doing a little bit of exploration, we discovered the nurses were actually documenting it elsewhere. So ongoing communication is really important, as Lori pointed out. So we took a look at the one-year mark at the end of February of this year at our compliance rates with each of the individual components of the bundle, as well as with the overall bundle. We did not routinely have a preoperative chlorhexidine shower, so that was a 0% prior to the intervention. And we actually had a wonderful 69.8% compliance with a preoperative showering 1 year after our bundle implementation. Our use of oblique or transverse incisions tripled from 13% pre-intervention to 41% post-intervention. And our use of post-operative showers in the first 2 days after surgery went from 33.9% to 94.3% after implementation of the bundle. Our overall compliance with all three components of the bundle was 30% at 1 year. So we took a look at what was happening with our wound infection rates over time, and we had 53 bypasses in this time period with 2 wound infections documented according to the VQI. Now, with the way data is input with lower extremity bypasses, this best represents our in-hospital wound infection rates because these wound infections were input at the day of discharge. Our true 30-day infection rate will be better reflected once we have our 9-month follow-up information, which is forthcoming. But this translates to a 3.8% rate of wound infections in hospital compared to our pre-intervention rate of 13.9%, so 72% reduction in our wound infection rate. Some of the limitations of our studies of this data was raw, it's not risk adjusted, and as I mentioned, there's a delayed input of the 30-day outcome data, so that is one of our future goals. We also got a lot of feedback from our fellows and our attendings that the oblique incision may not be appropriate for all clinical scenarios. It may offer too limited of exposure for certain cases, particularly for concomitant femoral endarterectomies or for reoperative groins. So our future directions, currently Northwestern is working on transitioning from PowerChart to Epic. So we are working on building our pre and post-operative shower orders into Epic and ensuring the documentation, our templates get carried over into the Epic Smart Phrases as well. As I said, we are going to reevaluate our infection rates at the 9-month collection mark to get a better assessment of our 30-day wound infection rates. We would like to expand our bundle to all lower extremity bypass surgeries, not just those with groin incisions, and include our project materials and new RN training, and encourage our nursing leadership to continue to incorporate this SSI reduction project into their ongoing quality of initiatives. So with that, I'd like to thank Dr. Andy Houle for his mentorship in this project, and really many, many thanks to my entire division of vascular surgery inpatient and outpatient care team. Their enthusiasm and support of this project really made this possible. These are my references. Thank you for having me.
Great. Well, thank you very much, Dr. Heckman. And now, for those of you that have questions, please go ahead and put them into the chat box. We've had a couple of questions asking about slides and transcripts, and all of that information will be sent to each of the participants, and the slides will also be available on the VQI website. I had one question for both of our presenters, and that is, and Lori, we'll start with you. If you could talk a little bit about the biggest challenges, surprises, and unexpected pieces that have emerged from starting your project.
Thank you, Eugene. Let's see, the biggest barrier so far, probably schedules. I'm getting schedules together for, you're working with physician schedules, you're working with staff schedules for the diabetes center, for the wound care center, for hyperbaric oxygen. And then we're a private hospital, so we have private physician practices, which are all over. And so trying to get everybody together from where they're at back into the Charleston area is, that so far has been our biggest constraint, just trying to figure out what days are available for what physicians, for what staff, and just to keep everybody updated on the project.
Right. No, I appreciate that, and part of this is just to let people know, as many of you are aware, quality improvement projects are a new feature for the participation awards that are coming up for 2018. And so we also want to let people know that we anticipate there will be challenges, that there will be setbacks, and some of it is as simple as just getting people together in one room, lots of other things. So thank you, Lori. And then Katie, do you have particular challenges from the academic medical center perspective?
Yeah, I think I mentioned that really one of the ongoing challenges was just continuing to close the loop of communication and soliciting feedback and incorporating that feedback into the project. I think specific to the academic center, though, we certainly did find there was a not trivial amount of bureaucracy in some of the aspects. In order to get the shower orders built into our order sets, it was about a 6-month delay between submitting the idea and actually getting approval to having that rolled out. There there were also many features of the bundle that ended up getting struck out because it was deemed too redundant by leadership. So there was a lot of editing of the process through all the different many layers of leadership as we were developing the bundle.
Great. I don't see any other questions coming in at this point. If you do come up with other questions, please feel free to email me, Nadine Caputo, and that's ncaputo@svspso.org, or after you've reviewed the slides and you have questions, we'd be more than happy to answer them. So thank you, everyone, for your attention, and we hope to have you participate in future webinars.